Welcome to my podcast. Today I'm going to talk you through one of the common cases that you can face in the clinical setting or the GP setup. So it's basically a patient will come to you, and after we introduce ourselves, as always we agree, double check the patient name, date of birth. You will ask the patient, how can I help you today? The patient might be in their 30, 40, this kind of age, and they will present with mild itching, and they have noticed that started like a month ago, and they find it's really annoying, irritating that they keep scratching their armpit or the axilla, and they find it very embarrassing. And when they glance in the mirror, they find or they can appreciate a tiny or a faint redness or brownish macule, and they feel it's getting worse. And they can't see anything else apart from the armpit, because we know if there is something in the back or the chest, that's another thing. And they tried certain medication or certain creams that they bought OTC, or maybe they asked the pharmacist, and doesn't seem to work. You'll ask the patient, do you have any thought what might be the reason for that? Maybe the patient traveled somewhere, wore something new, or shared clothing or towels or wherever. And you will ask the patient if they have any past medical history or any medication that they are taking. The patient will say, yes, I'm taking certain medication for controlling her diabetes and her hypertension. And you notice that the patient is quite obese or overweight. And you'll ask the patient what sort of work do they do, their social life, and their lifestyle ways. For instance, what sort of food do they eat, if they do any certain activity, and you take it from there, of course. Then you will say to the patient, can I have a quick look about the issue, and then we can come up with a management plan. And when you glance through the patient armpit, you're going to see well-defined wrinkle-like plaque. However, it's scaleless. I mean, there is no scales and there is no lymph node. And in that condition, you need to think and put certain differential, like for instance, fungus or candida. We know that area also affected by acanthosis nigricans. Also inverse psoriasis, also contact dermatitis. However, the contact dermatitis, the picture would be quite different, and the patient might say that she used new, maybe Dirol, those kind of hygienic thing. And the other thing you need to think of, which is also can affect the other body fold, is erythrasma. So you need to check if the patient has anything in her crura or any other part of the body fold of the body. So when we think about candidiasis, we need to put in mind the presenting picture of the candidiasis, which usually red plaque with satellite lesion, which is the main distinguished feature. However, for the acanthosis nigricans, it will be thick, velvety, and can be very dark. I've seen a lot of cases in my practice, and it will have like that subtle accentuation and deep skin marking. In the case of inverse psoriasis, when the patient has only inverse psoriasis, so it's going to lake the scales because of the body fold and the friction, and it will be pronounced redness, basically. However, for the contact dermatitis, it will be too much oozy, and it will be red as well, and there is no scales. And we know the measure basically in all of that things that you need to keep the skin clean and dry in order to minimize recurrence in the future. And we know those kind of places, by default, it's very hard to keep them dry, so you're gonna give certain advices like try to have a small towel dew, wear cotton underwear, and keep the place aerated, so avoid any tight clothing, especially polyester or nylon. And yeah, and then when you examine the patient and you had those thoughts in mind, and as the picture here seems to be inclining more to erythrasma, so if you have the Woods lamp, that will confirm the diagnosis, and you will see the typical coral red fluorescent, which imply superficial skin infection with gram-positive aerobic bacteria called Corynebacterium. And it's, this bacteria is mostly affecting the intertriginous areas, as I say, armpit and the crura. It can extend to other body folds. However, this is the main places. And with superficial fissuring, if you had a close-up examination. However, in the dark skin, it will be too much dark, and in certain places can be far more pronounced. And some people, they will think it's a dirt, and they're gonna use the body sponge, the harsh one, to rub it, which of course will cause increasing in the darkness, because it's a complete different story. And the red coral fluorescence occurred due to the copper porphyrin released by the bacteria. In those kind of cases, we need also to think about the risk factors, which I mentioned. It's mostly if someone is obese or overweight, so they have excess body fold on the skin, and that area will be moist, which harbor growth of the bacteria. Diabetes, as we all know, if the patient is excessively sweating, and if they live in a place where too much humid, and if they are diabetes, as I mentioned already, and in certain age group like advanced aging can be another issue. So if we, for instance, the patient did not present early on or just ignore it, so it might be complicated, for instance, with contact dermatitis, and might get thickened with time, so it's gonna get like unification. It might get darkening, so the patient might have post-inflammatory hyperpigmentation or co-infection with bacteria or yeast. And this bacteria cause sometimes, in certain cases, though it's very rare, it might cause abscess, cellulitis, meningitis, endocarditis, this sort of things. However, they're quite rare. And erythrasma, I mean, it's not just you need to treat topically, you need to treat systematically. And one of the treatment of choice, as I remember when I was treating my patient, so it's erythromycin that you need to give 4 times a day for at least a week or 10 days. And of course, you will give the measure for cleaning, keeping dry. And you might think about something topically to alleviate the symptom of the patient that he has. And of course, you get to give warning to the patient if the condition doesn't improve, if it gets worsened. Usually it doesn't, but always you need to warn the patient. If there is anything that doesn't seem right, always come back and we'll take it from there. So I hope by that I told you about one of the commonest case can present, which is related to the dermatology, and can present in the primary care setting to the GP. And you shouldn't miss this case, which is quite easy and easily distinguished to be spot on. Thank you, and I see you on another broadcast. Let me know if you have come across those cases. How did you manage them? And if you have anything, comment to me. I'll comment back to you. Thank you.